Hey everyone, welcome back to The Flush, brought to you by Birmingham Gastroenterology. I'm Julianna Hallman, here with Dr. Chris Shaver, and we are here to flush out the facts on GI health and talk about things that no one really wants to talk about, but everybody has questions on. How are you?
I'm good.
What's
I'm
new?
good. Not much. I'm itchy.
Why?
I'm really itchy.
Did
Do you know about my poison ivy?
I mean, I saw it. I just wasn't going to say anything.
I was working in the yard, and I actually have no idea how I got this terrible case of poison ivy, but if you see me scratching or squirming, it's the poison ivy.
Didn't
I don't
this happen
have
last year?
Yes. It's maybe.
Or 2 years ago?
Yeah, it happens every few years. And I just need to wear like a whole body suit when I work in the yard.
Do
That's
you
maybe
know
my solution.
that it's poison oak or ivy?
Obviously not,
Okay.
because I didn't just go dive in it.
Okay.
But yeah, sorry, but it does.
Clearly,
it
I
itches,
don't know.
and yeah. So topical steroids, Benadryl. If anybody has any home remedies for really bad poison ivy, please let me know. But yeah, I think the worst of it's over. But again, I might be squirming a little bit.
I think that you get this every year.
Maybe I do. Maybe I just
really
forget
do.
about
Or
it.
Was it last year or was
Usually
it a
it's
year ago?
not as bad as like
But remember you had
half
it when
my
we
body.
took your headshot.
I do remember that. Mm-hmm. Yeah.
So that's why I can't remember that
it's
was
not
last year or 2 years ago.
attractive, and when it gets, it's like in the weepy
Are you going to
stage.
show the camera? Oh my Lord. It looks like you got a really bad sunburn.
In Alabama, we would call this the whelp stage. Got some whelps.
I cannot believe that.
So yeah, whelpy and itchy.
Oh my goodness.
Not good, but enough about me. How are you?
I'm great.
Okay, good.
Yeah,
Have you gotten
thanks.
any
I haven't gotten any
no
poison
bad
ivy.
enteric infections
No,
lately?
thank God, no.
Okay, that's good.
No.
Because I hear it's going around
Again?
all over 18 states.
Oh, that.
Nah, yeah, a little teaser there.
That. Yeah, no, thank
Little
God,
teaser.
no. That sounds like a fun time. Just like your poison ivy.
Just like my poison ivy.
Is it poison ivy or is it poison oak? That's what I want
I
to know.
think I was cutting a tree fell during one of our torrential rainstorms, and I was cutting up the tree so I could throw it into the woods. I think I got into some poison oak there, but obviously I didn't really realize it at the time.
You get some long sleeve outdoor.
Paying the price. When it's 98 degrees, it's hard to wear long sleeves.
But if you wear like the one that's like the sun protectant, that's like
a sun shirt, I don't.
outdoorsy.
Shaver doesn't do sun shirts. Sorry.
Figured. But it might help your situation that are recurring. Bless. Okay, let's get into Hot on the Pot. Our first Hot on the Pot headline is explosive diarrhea parasite is surging in the United States, and the officials are saying to follow certain precautions. So I think everybody has heard about this explosive diarrhea situation. That does not sound fun at all. That sounds miserable. There's been a recent spike in cases of, you're going to have to help me pronounce this word. There's been a recent spike in cases of Cyclospora.
Psoriasis.
Okay, psoriasis. Okay, now I see.
Not psoriasis. That's what I feel like I have.
I was about to say cyclosporiasis.
Psoriasis.
Oh, okay. We're just gonna let you say that word. I'm just gonna call it explosive diarrhea parasite. An intestinal infection caused by the parasite Cyclospora. Oh my gosh, I feel like
that's
an idiot.
right.
Okay, great. Thanks for teaching me. I'm still going to say it wrong. With cases reported across multiple states, health officials are still investigating the source. The headline.
Should we do it like Sesame Street?
Yes.
And
Spell it out.
cyclo, you say spora.
No,
you say spora.
Okay.
Cyclo,
Spora.
Sesame Street. We got it. Okay.
Sporas. Okay. Cyclosporas.
Just say cyclospora.
Cyclospora. Okay. Anyways, so this headline for Hot on the Pot focuses on explosive diarrhea, but that's actually one of the classic symptoms, just one of the classic symptoms. Other symptoms include loss of appetite, nausea, bloating, fatigue, abdominal cramping, and diarrhea that can last for weeks if not treated. So people usually get infected by eating contaminated fresh produce or drinking contaminated water, not from casual contact with someone who is sick. In previous outbreaks, foods like cilantro, basil, raspberries, and leafy greens have been linked. Unlike a typical stomach bug, this illness often doesn't go away in a couple of days. Symptoms can come and go for weeks. So persistent diarrhea after eating fresh produce or traveling is worth discussing with your doctor. So, what are your thoughts?
My thoughts are, well, I haven't seen a case yet.
That's good.
I expect I will.
Is it in Alabama yet? I don't think
I
so.
don't believe so. And it started up, I believe, up in
Michigan or something?
in Michigan, the Great Lakes area, and probably is trickling down. And so my thoughts are, well, I like to always bring a little history
Yes.
into our discussions about even explosive diarrhea.
Right.
And isn't it satisfying to say explosive diarrhea? I don't know. There's something about it. It just sort of rolls off the tongue. Explosive. I mean, is there non-explosive diarrhea? I mean,
That's what I
a lot of diarrhea is
rank
explosive.
the
So that's
diarrheas.
not unique to cyclosporiasis. So Cyclospora is the parasite, and so it's a parasitic infection. And it is typically not chronic, but that's what's interesting. And to get into the history is I've been around long enough to remember when medical units in hospitals were full of AIDS patients. And that was typically in the 80s and 90s. And in big cities, and I did my residency in internal medicine in Charleston, South Carolina, which is a relatively medium-sized city. We had infectious disease wards full of patients with AIDS. It was tragic time to take care of patients because they were about the sickest people you'd see when they were end stage. And there are books written on diarrhea, chronic diarrhea in AIDS patients, literally books, because it was a huge problem because if you had AIDS, you were likely going to have some form of chronic diarrhea. And you would get sort of atypical infections or weird infections because those patients were so, like their immune system was wiped out. And that's how they died. Was overwhelming infection. No. There were other infections, but they wanted to be dead from the diarrhea. We're going to have to bleep that out. But
I don't know. I think
that's
I might
funny.
keep it.
But back to my point is so immunosuppressed patients, historically like AIDS patients, or perhaps really young patients or really old patients, this can become subacute. It can last for a lot longer than normal intestinal infections. Or if you're really immune suppressed, it could become chronic. And this is one of those sort of atypical infections, kind of like cryptosporosis and Cyclospora and some other of these sort of atypical infections that could become chronic in the severely immune suppressed. So that's one thing I wanted to bring in that I think is interesting and historical. But my other thought is it is prolonged. There is treatment. And
What is treatment?
antibiotics.
Okay.
And so, rehydration first. Don't infect other people. So hygiene to not spread this to other people because it is contagious. Typically, it is transmitted fecal oral in fruits and vegetables, like you were saying, which is gross.
Yeah.
So hygiene goes a long way to preventing this from spreading. But once you got it, you want to try to mitigate symptoms and shorten the disease duration. So antibiotics, Bactrim or Cipro would be the first and second line. And then the other important point is, and this is for our primary care colleagues, is that it requires a special test to find it. you can't order ova and parasites on stool testing and see it. You have to have special requested stool microscopy where they do special stains, or you have to do what we call a PCR test. So I'm actually not sure which of our labs in town can test for that right now. I hope most of them. So you do have to actually think about it and order a special test to try to find it.
Wow.
Yeah.
Would you see this on a scope if you did a colonoscopy on somebody?
You would not.
Okay.
And I hope I don't have to scope a patient with this.
That would be.
No, yeah. So the good news is it's not going to be lethal. I mean, this can cause morbidity, and it can cause you to be out of commission for a while, but it won't kill you.
It's just going to be explosive.
It's going to be very explosive,
but
apparently.
Not the lethal explosive.
Not the lethal explosive, which is good. So
how would somebody know that they have this versus another just general stomach bug?
You wouldn't, really.
Okay.
You know,
I guess this one might last a little bit longer too.
This one, yeah, I think that's a good point. So if you just couldn't kick it and you just kept having symptoms, then that may be a sign. But other than that, explosive diarrhea is caused by lots of different things. And so you really can't tell based on symptoms except maybe duration.
What would happen to a patient if they had IBD and they got this?
Well, I think what would happen is that they might think that they were having a flare of their IBD, number one, and it was just the infection. Or number two, they might get the infection, which might trigger a flare of their inflammatory bowel disease. So I think one of those two scenarios may be something you might have to deal with. So still have to think about it and not just blame it on their Crohn's or colitis.
Yeah. If somebody has diarrhea that just won't go away, when would you say is the time? How long would they need to wait until they came to see a doctor?
It depends on the severity.
Okay.
I've seen some patients with infectious diarrhea get really sick really fast, and some infections are potentially lethal. So there are strains of E. coli. I've seen super sick patients with salmonella because they can become septic. And E. coli can be associated with a really serious condition called hemolytic uremic syndrome, which can be life-threatening. So while almost always it is self-limited and you don't get really sick, if the symptoms become quite severe, dehydrating, or associated with rectal bleeding, or other symptoms or signs of toxicity like low blood pressure, passing out, high fever, things like that, then you'd want to be seen sooner rather than later. If you're just not super sick, but you just don't feel good and there's been a huge change, I'd say after about 2 weeks, definitely a month, you should see us about it.
2 weeks.
2 weeks,
Diarrhea,
it kind of lingers. If it's not dehydrating, like I said, and you just kind of limping along and just not turning the corner, then we might need to look and see, is this some kind of chronic infection like Cyclospora, or is it something else going on?
What are other parasites? How does this differ from another parasite that you would see?
Well, there are several types of parasites that can affect humans, and again, the symptoms are very similar. Some our bodies can kind of handle and get rid of on their own, like this one. Others, they just have figured out how to survive in the human gut and kind of hang out there for a long period of time and wreak havoc. And so, so I think the main difference would be this parasitic infection is typically self-limited, except the example of the AIDS patients, the severely immunosuppressed. Other parasites like Giardia or Giardia and some others.
Cryptocurrency?
can be chronic and can lead to weight loss. And without specific treatment, you're just going to keep having symptoms. It becomes chronic.
Did you see the picture of or maybe it was a video of the parasites that Dr. Kakati recently found?
I haven't seen that.
We need to get it.
Okay.
But a lot of people think, I mean, we know this, I know this from being on the internet, and we've kind of discussed this briefly, but a lot of people think they have parasites, and that's not a common, I mean, this explosive diarrhea parasite, yeah,
right.
But like normal parasites that everybody's buying, all the cleanses on, it's not for real. Like, how many parasites have you seen or diagnosed in your...
They're not very common.
Yeah.
Real parasitoses aren't very common, and some people will get hung up on that, and it can become a bit of a phobia. And it's actually called parasite phobia or parasitophobia. Parasitophobia. I think that's the name. I think that's a word.
I can't pronounce that.
Is that a word? I think it's a word.
Sure.
So don't get parasitophobia, but it is something that we think about and often test for. Rarely is it positive. Again, the one we see most commonly is going to be Giardia, which again is transmitted similarly usually through contaminated water sources.
Yeah. Like, I had a friend that got that when she was camping.
Yep.
So, not fun for her. She was like, "Can you please get somebody to call something in for me?" It was bad. Okay, so you already talked about treatment, like being antibiotics. Do you think it usually clears up pretty quickly once it's identified and once you're on antibiotics, or is it still like you gotta kind of like
it still takes several days and a full course of treatment to really eradicate it.
Okay.
And sometimes these atypical bacteria and parasites can be a little bit refractory to treatment, so you got to make sure the patient takes the full course of antibiotics. But usually within several days, the symptoms will improve, but not right away.
Yeah. That's unfortunate. I feel bad for all the people. We don't have any confirmed cases in Alabama yet. I looked that up.
I did get, my wife texted me an ex post today, like about an hour ago. And again, no, I haven't validated this at all, but apparently being found in fruits and vegetables in Cisco supplied restaurants and Taylor Farm products. So that is the scoop I have on this from this afternoon.
Did somebody just like get their feces?
Well, yeah, it started at the farm level, and someone who was probably gathering and distributing the fruits or the vegetables. I remember there was an outbreak probably 10 or 12 years ago that was raspberries. Raspberries stick out in my mind as a historically as a vector of Cyclospora.
Why?
I don't know. It was raspberries. I mean, it can be any berry.
Do you not eat raspberries?
But I don't like raspberries very much. But it's my least favorite berry.
Really?
It's kind of bitter to me. I just don't like them.
Well, I was eating a peach last night, and I reached for it, and I was like, I second guessed it. I was like, do I eat this? Are we not supposed to eat healthy anymore? Because I was worried.
Peach hesitancy. Okay, I see.
I mean, I love peaches. I just bought these, but
Chilton County peaches?
I don't know if these were from Chilton County, unfortunately. I should have gotten some when I was in Clan last week, but I did not. I completely forgot. But I was worried because I'm like, where are these parasites? Are there parasites on here? Obviously, I washed it, but still. Does washing it, I guess it doesn't help if it's all over.
That's actually that's a good point. Washing will probably help, but because it'll wash off the contaminated fecal material. But once the infection is there, it can be hard to kill with just standard cleaning materials.
Boo, that's so gross. Well, I hope we don't get it here. Hope you don't have.
Let's hope not.
Yeah, let's hope not. Even though, you just said Cisco, and I saw a Cisco truck on my way here. Mm-hmm. Okay, our next hot on the pot headline is Biohacker hoping to live to 160 reveals alarming diagnosis. My stomach is eating itself. you sent me this, but the biohacker Bryan Johnson is 48 years old, and he is known for his longevity experiments and a goal of living to 160. Recently revealed he has an autoimmune condition causing his stomach to eat itself. He says he was diagnosed with autoimmune gastritis, a condition where the immune system attacks the stomach's acid-producing cells. And he just kind of mentioned that he became a young father of 3 and began building a business. And he was juggling stress, and he kind of let his health slip, and he gained 40 pounds. Within a few years, he had fallen into a deep chronic depression, and somewhere in that timeline, his body began developing an autoimmune process affecting his thyroid, and then his stomach lining is what he added. And he was diagnosed with after an upper endoscopy, colonoscopy, and stomach biopsies that showed early autoimmune gastritis, and there is no cure currently for that. And Johnson says he plans to share his journey as he searches for ways to better understand and manage the disease. So you want to talk us through that and like what is AIG?
Well, he blamed his 3 kids.
Yeah, no, and that's
so that's where we start is if you don't really know the cause, blame your children.
Yeah, the stress.
That's healthy. No, I'm just kidding. I'm just kidding, Brian.
No, he kind of did that. Let's be for real.
Yeah, I know. But I gained a bunch of weight when I got married because I married a woman who could cook pretty well. And so that's where and I did get pregnant along with her, and I gained extra weight with the children, like when they were in the womb.
Yeah. What's that called? What do people call that? Sympathy weight?
I guess it was sympathy weight. Yeah. It was a lot of sympathy weight, like double chin sympathy weight, but
I need pictures.
Yeah. So there are pictures.
I believe it.
Not that many. But so first of all, his stomach, that's a clickbait title.
Obviously.
That I think wherever we pulled that article from. So clickbait title, although in a sense it's true, but it's very hyperbolic. So autoimmune gastritis is an autoimmune condition. Like you did point out, it's very often associated with other autoimmune conditions like autoimmune disease of the thyroid, like type 1 diabetes, like other autoimmune diseases. And so that's interesting. And when you make the diagnosis, you really need to think about and screen patients for other autoimmune disorders. But as a gastroenterologist, I'm most focused on what it is and how it's diagnosed and how it's treated. Let me just say, I'm intrigued by these longevity guys, and I'm just I just think it's really interesting. And the other thing that really jumps out is that his goal is to live to 160, which is so audacious and so unrealistic. And that's kind of why I love it. It's kind of like makes you gulp, like 160. No one's ever lived to 160 in non-ancient Bible times, right? So I think Methuselah, the oldest man that ever lived, 985. Was his age.
Could you imagine living
old as Methuselah? He was old. So they were doing something right back then.
Yeah.
And so all we're doing is a poor attempt to try to recreate long life like in ancient Bible times. But 160 is insane, but that's why I kind of admire and respect what they're doing. However, if your goal is to live to a certain chronological age, you're not going to get there. I hope that there's something else driving you in life. There needs to be. So I hope that's not his whole goal.
Not his kids.
Because I think that there are a lot more. I think if you had your list of your top goals in life, the age you want to live to, I think it should make the list, but I think it needs to be bumped down by a lot of way more important things that might actually help you to live to a ripe old age, because if your purpose is just to keep living, then I'm a little concerned about you. But that being said, I'm getting off track.
Well, I was going to ask you a question. What is autoimmune gastritis?
It is the autoimmune destruction of glands in your stomach. And it's we don't know what causes it, but your body develops antibodies, and they attack your own stomach. And they target various, they really target a proton pump, and then that recruits more inflammation, which destroys a couple of things. It destroys the ability to make acid in the stomach, and it also creates antibodies against something called intrinsic factor, which is what you have to absorb vitamin B12. So the symptoms are usually nil. You don't get symptoms, or they're very mild. So one thing about this disease is you can have it for many, many years and not even know it. So it can be very minimally symptomatic or asymptomatic. But it presents usually with maybe some dyspepsia, filling up quickly when you eat, minor symptoms like that. And sometimes it'll present with manifestations of vitamin deficiencies like B12 or iron or vitamin D.
How do you diagnose it? And like, is this something you can see like when you're doing an upper endoscopy, or how do you diagnose it?
Well, you diagnose it with endoscopy and with follow-up blood testing. Okay. So it does look like, so what we see is a flat stomach, an atrophic stomach, a stomach that looks featureless, and then biopsies will confirm it. And then if we see that, then we'll do follow-up blood tests to confirm it, which we can check the autoantibody levels to both the parietal cell in the stomach glands and from the stomach glands and the intrinsic factor. So we can check those autoantibodies with blood tests.
When someone is diagnosed, do you focus mainly on managing like the vitamin deficiencies and monitoring like symptoms or complications if they are having those, or are there like any treatments to be able, I mean, I guess it said there is no cure obviously, but are there any treatments to help?
Yeah, that's the main thing is vitamin deficiencies. Okay. So when these patients become B12 deficient, that's called pernicious anemia. And so their B12 needs to be replaced so that they don't develop symptoms of B12 deficiency. And what you need to know about that is you can't take B12 by mouth over the counter because what? You won't absorb it because you can't. So you could take like hourly B12 and not replete your B12 because you have to have intrinsic factor. So you take it injections.
Okay. Does it matter? There's different types of B12. Does it? I mean, I guess it just.
No, it's all pretty much the same. There are different ways to get it into your body. Another way is through the nose, but that's just not very. Most people don't like intranasal squirts of B12. So injections usually are the most effective and most widely available and most cost effective. The other issue you need to check is iron, make sure their iron's replaced, and then check for other vitamin deficiencies like vitamin D, folate, even vitamin C, and just make sure those are replete. And then the other thing about your question is that they are at increased risk for stomach cancer. There's two types. There's gastric adenocarcinoma, and there's what we call gastric type 1 neuroendocrine tumor, or GNET. Type 1, and those are tumors that you need to perform surveillance for periodically because the risk does go up in this condition.
Good to know. I was looking up I assumed he had when he said that he had thyroid problems, that he had hypothyroidism, and he does. So, but he blamed it on his children.
He did.
That's really, wow.
Easy target.
Easy target for them, giving them hypothyroidism and AIG. Okay, next hot on the pot headline is are heartburn medications making stomach symptoms worse? There was a new study that found some interesting things. A new study looked at people with functional dyspepsia, a condition that causes symptoms like feeling overly full after eating, getting full quickly, upper stomach pain, and burning, like heartburn, despite having normal upper endoscopy. Researchers found that 60% of patients with functional dyspepsia were taking acid-suppressing medications like PPIs or H2 blockers. Surprisingly, those taking acid-suppressing medications reported more symptoms, including early fullness, nausea, and upper abdominal pain. The study does not prove this medication caused those symptoms. It only found an association. It's possible that patients with more severe symptoms were simply more likely to be prescribed acid-suppressing medications, and the researchers say more studies are needed and patients should not stop taking their acid reflux medication without talking to their doctor. So what are your thoughts? What's functional dyspepsia fully? I mean, I kind of explained it there, but you're a doctor, so I'm going to let you explain it. And then what are your thoughts on that study?
Functional dyspepsia is hard. And so what I'm going to tell you what it is, and then I'm going to editorialize a little bit about it, and then talk to you about what I think about the relationship between functional dyspepsia and medicines like when we say PPI, proton pump inhibitors like Prilosec or Nexium. Functional dyspepsia, so the fancy term, fancy words, microinflammatory, neurodegenerative, disorder of gut-brain interaction, lots of fancy terms. It's basically when a patient feels nonspecific upper abdominal discomfort, possibly with bloating, possibly with nausea, possibly with filling up quickly after eating, possibly overlapping with irritable bowel syndrome. That's how they present to us. And usually they present in a chronic fashion, like this is going for years and years. And it's incredibly frustrating for the patients. And so that's basically what it is. So dyspepsia is discomfort of the upper abdomen, and functional means sort of related to the function of the gut, which is kind of an old archaic term, but still helpful. So that's what it is. And so patients come with this set of symptoms and they want to feel better. And so we do test patients, and usually that's going to involve blood work, possibly imaging of the gallbladder, and then usually an upper endoscopy. And do you know what the usual finding is on upper endoscopy? What do you take a stab at it? They could have a hiatal hernia. That's true.
I don't know.
What else? And so, all right. So usually it's normal.
Okay.
Or near normal. So that's one of the frustrating things about functional dyspepsia is a lot of times patients have these very real and pretty debilitating symptoms, but I come to them and say, hey, everything's normal. Like your tests are normal. And they're like, and so there's a little bit of sort of disbelief. Like, you're telling me I feel this way and my tests are normal? So for that reason, a lot of these patients doctor shop and get second, third, fourth, and fifth opinions because the symptoms, again, are chronic and come and go and can be very frustrating. It's frustrating for doctors, and so we need to ourselves communicate very well. And one of the ways to get in front of the frustration is to name it. Call this what it is, and to know how to treat it. And there are treatments. They're not perfect, but they can be effective. Yeah. So that's kind of my intro on functional dyspepsia.
Well, so since the study found that the patients taking acid-suppressing medications reported more symptoms, does that mean that these medications are making people have symptoms and making their symptoms worse?
I don't think so, because these patients are often put on acid-blocking medications to try to alleviate their symptoms. And so that's really confounds a study like this because, again, a lot of them have either been on them in the past or are on them chronically, and still have symptoms, but they were prescribed the medication for the symptoms. So, so it's a little hard, and I didn't look at the study. I didn't know if the methodology of the study. But it's really hard to say that it's causative when so many of these patients are on or have been on that medication.
Yeah.
So I think it's a leap to blame it on the medication. Also, some of those medications do cause dyspeptic symptoms as side effects, so that's something else to think about. So sometimes I'll just stop those medications when patients present to me with dyspepsia to see if that helps. But no, I definitely would not blame a majority of these patients' symptoms on PPIs.
Yeah. Well, so you mentioned, so many people have normal endoscopies. If someone has symptoms or like persistent fullness after meals, but a normal endoscopy, what are like next steps? Like, what would you do next after you found a normal endoscopy and they were still having symptoms?
So I think a couple of thoughts. This is where you have to talk about the art of medicine and how to communicate challenging diagnoses and how to explain it to the patients at the bedside and how to help them to understand kind of what they're going through. Because a lot of these patients do have some other overlapping symptoms that can relate to mental health, chronic anxiety, depression, and things like that. So there is an overlap there. And so if you're not careful, some of these patients can leave your office thinking, that doctor thinks I'm crazy, or that doctor thinks it's all in my head. And in a sense, part of it is in the head of patients because there is a relationship between what's going on neurologically and psychiatrically with what's going on in the gut. There is a brain-gut connection that is heavily involved in this condition. And so it has to be addressed, and doctors have to go in there and address it, but you have to do it with a lot of explanation and tact. The other thing I will say is this is where you get to there are a couple so back to the art of medicine. So when you're dealing with functional dyspepsia, this is where you need to really take a good history. And we have come so far with diagnostics in medicine and with, the testing is so readily available, CT scans, blood tests. We often don't think about the cost of those. They have gotten cheaper overall in a lot of places. But you do have to really take a good history. And I don't think doctors are as good at that as they used to be. And so you have to ask a lot of questions and really understand the story. And sometimes patients will tell you what's wrong with them if you let them. And you give them time to answer questions, if you ask open-ended questions. And this is where gastroenterologists can shine with these patients and can sometimes come away the hero because you can ask the right questions or lead them to tell you what's wrong with them. When I'm talking to students or advanced practice providers, I always tell them the patient will often tell you what's wrong with them if you let them. Yeah. So you got to let them talk and get their story out. And when you do that, number one, the patients feel heard. Mm-hmm. You want them to feel heard, but you also want to do your diligence and be a good investigator and do that because this is a condition that like multiple factors are involved. Yeah. And so you have to get the whole story. So, and again, that's kind of a lost art, yeah. But that's also kind of what makes it fun is to try to figure out some of these tough,
it's a little mystery,
tough patients. Yeah.
Well, to wrap up that headline, and then I want to circle back to something else that you said. What would you say to someone who sees this headline and is like, hey, I'm going to stop taking my heartburn medication?
Well, I wouldn't stop it based on the headline.
Yeah.
Because the headline, because again, like we talked about, this study is not conclusive, and you were started on that medication for a reason. And while I think it's probably safe to stop the medication, it's something that I would run by the prescribing physician before you did that.
Yeah. Well, circle back to really quick before we hop into our next topic, the gut-brain connection, the gut-brain axis, brain-gut, however you want to say it. And you mentioned like having the tact to be able to say to them like, hey, like this is really a thing. And I think people are starting to realize that, but it's still really tough for people to understand when you're like, hey, like I'm going to refer you out to somebody that can help with that. I think it hurts a lot of patients' feelings a little bit, and I think that there's a much better way for providers to go about saying like that. And I think we could do a whole episode on IBS and on the brain gut, or the grain. Maybe we should call it that, the grain.
The grain gut.
The brain gut axis. And yeah, I think that we could talk about that because it is real, and I think people, like you made a really good point about having the tact to be able to tell a patient, like, it's not like you're not crazy. It's just a real thing. And a lot of people struggle with it.
Well, they used to blame it on the uterus.
Good to know.
So we've come a long way in some regards. So it's not all bad news.
Wow.
So at least we don't blame it on, it was called, again, we like to introduce historical pearls here at the Flush. And so I believe it was called a floating uterus. But yeah, so like old medicine 1.0 would blame a lot of things on the uterus and on women in general. So it's not a floating uterus, and it's not all in your head. Floating uteri. Can we like use that to tease this episode?
Yeah, we'll
it's
just
not
call
your uterus.
That's what the name of that episode will be.
But yeah, so it's not your uterus, and it's not all in your head. It is seen more commonly in women, and so that is real, but it's not the uterus. But these conditions, so we know so little about the brain gut, but we do know we're learning more. We're learning that there's a central brain and a peripheral brain, and they do act, they communicate, they talk back and forth. And inflammation in the gut, whether it's from cells called eosinophils or mast cells, which make histamine, or autoimmune types of cells, cells that are triggered by an infection that you caught, like cyclosporiasis, can rev up inflammation in the gut. This is inflammation that we may not see on endoscopy, but it's going on. It's microinflammation. It may be low-grade autoimmune inflammation that doesn't really show up in blood tests, but it's there. If you do full-thickness biopsies, you can see it. You can stain for it. And so that sets up a cascade. It triggers secretion of hormones. It triggers nerve impulses that go up and down the spinal cord to the brain. And that affects gut function. It affects gut secretion. It affects how you perceive pain. And that is, it's a gray area to try to take all that and package that and tell the patient, you've got functional dyspepsia. And that may explain why you have heightened anxiety that sometimes occurs when you have symptoms. And it's a little bit what came first, the chicken or the egg. Does your gut symptom make you feel anxious, or were you chronically anxious and that's feeding into the gut? It is a bidirectional type of situation. So I'm still trying to hone my craft on how to deliver that messaging so that patients can understand it and we can get our arms around it. Sometimes it's a huge win just to understand what is happening to me? I'm not crazy. It's not all in my head. That's huge. We can get into treatment if we want, or we can save that for another episode. But it's really fascinating. It brings in things like the art of medicine, history taking, things we have to be really good at, and then also just being a good communicator at the bedside so that patients understand, and you're not just saying, I don't know what's causing your problems. I don't know. Go see a dietitian. That's not really effective communicating. Go back to your primary care physician.
Yeah.
That's not what we want to do. But there is a role for a primary care to be involved. There is a role for a dietitian. It needs to be a team approach. But we gotta communicate that and understand it.
Yeah. And we are at Birmingham Gastro about to start working with a brain gut specialist in-house.
Glad you mentioned that.
And we're super excited because I think he's going to be very helpful. And with our dietitian, we'll be in our integrated care center. So excited about that.
Yeah, there's an algorithm for treating functional dyspepsia. And the first step in the algorithm is a proton pump inhibitor that you just bashed.
I didn't just
the
bash
article,
it.
I know. But further down the algorithm is cognitive behavioral therapy, which BGA now is proud to offer to these patients because, again, not every patient's going to respond to the same treatment in the same way.
Yeah.
And so, and then I also, I always preach about fundamentals and healthy behaviors. And so while I think functional dyspepsia is real, and I think you have to do some specialized interventions, I also think that the basics are huge, like what you eat, what you drink, what you don't eat, what you don't drink, not smoking. That's a big risk factor is tobacco, and other things that de-stress the body, like moderate consumption of social media or less than moderate, and getting enough sleep at night.
Yeah.
And not overdoing it with energy drinks and on and on and on. So there's certain things that you also can't overlook in your zeal to fix the problem. It's an opportunity to get patients back to kind of fundamentals of wellness, which I think is also overlooked by physicians.
Yeah. Well, we'll have to do an our brain gut episode later on because I think that'll be good and help people understand your doctor's not calling you crazy. Your doctor's just, maybe they are, I don't know. Just kidding. But they're just trying to help you figure out treatment and how to manage symptoms. And it's could be a lot more than just GI stuff too. So
we're all a little crazy in our own unique
we are.
And beautiful way.
I know.
But yeah, it can sometimes get out of control in some people. Right?
All your patients that you've pissed off by telling them if they need to go to a counselor are going to come in the comments. I'm just kidding.
I don't think I really said that, did I? Oh my goodness, edit that.
I'm never taking it out. Okay, next on the pot headline is taking laxatives can help with memory and attention span problem, and that's a study. I think I said that completely wrong. Taking laxatives can help with memory and attention span problems. Study. Okay. Talk about a gut-brain connection. Scientists have long known about the link between our stomachs and our brains. Wow, look at this. It fed in perfectly. Warning that our diets and gut health have a large impact on mood and mental health. And a study published Monday, which this was not Monday. Okay. I'm just reading this article. A study published may have found a way to flush the brain fog and attention issues that accompany depression down the toilet. The study actually looked at, I don't know this word.
Prucalopride.
Thank you. I think I need to go back to school. Prucalopride.
Pride. I
just don't know how to say doctor words sometimes, even though I'm an MD, asterisk. a prescription medication used to treat chronic constipation, not over-the-counter laxatives like Miralax or Dulcolax. Researchers gave the medication to people with a history of depression who were experiencing lingering problems with memory and concentration. After about a week, participants taking this medicine performed better on some memory and executive function tests than those taking a placebo. The researchers found or think the benefit may come from the drug's effect on serotonin receptors involved in both the gut and the brain, not because it acts as a laxative, but more research is needed before this would ever become a treatment for memory problems. And then there was like a doctor that was quoted in here that says evidence suggests that the gut microbiome may influence inflammation, metabolism, and brain function through the gut-brain axis. So, wow, what a great article to end on after we just had that conversation. But what are your thoughts? Do you need to prescribe this for me because I have a terrible memory? Do I need to be a test subject? I don't is it going to help my brain? I'm just kidding.
Well, it's almost like if a laxative helps you think more clearly, then let's go eat some raspberries because we'll get a laxative effect for like a month. So let's raspberries for snacks.
Or you just get the
raspberries
explosive
from,
diarrhea.
What was the name of that farm?
Cisco or Taylor Farms.
Taylor Farm.
Is
Taylor
like
Farm
the salads.
raspberries. Let's go. We might have explosive diarrhea, but we will be thinking clearly and
about
sharply.
Your explosive diarrhea.
So my take on this is it's an interesting article, and we certainly shouldn't draw any conclusions. This is what we would call in the business a hypothesis-generating study, not a definitive study that you want to make any clinical decisions on. And it would be certainly very much off-label for prucalopride. And so that's my kind of initial take on this study. What else do you want to know?
Well, how is prucalopride different than over-the-counter meds that people, or laxatives that people are probably thinking about, like Dulcolax, Miralax?
Prucalopride's not a laxative, firstly.
Oh.
And so, and most data, if you do a sort of a literature review on the effects of laxatives on most people on chronic laxatives actually have a negative association with their mental function. So, two exceptions, senicides like Senocot or Senna and magnesium oxide. So there are a couple of products that have been shown to have some positive correlation with mental acuity. Most have a negative association with the mental acuity. So I would say that laxative in general should not be looked upon as a way to improve memory.
So I still need to be taking omega-3.
Omega-3 would be good. So there's that in terms of laxatives. An exception to that would be a patient with underlying cirrhosis, because we do use a type of laxative called lactulose to evacuate the colon to reduce ammonia levels, which may improve executive function in somebody with chronic liver disease. So that's a special situation. So I'm wondering if some of these patients have occult or hidden liver disease, and we're treating their cirrhosis with hepatic encephalopathy. Probably not, but that would be one explanation. So back to prucalopride, it is what we call a 5-HT4 agonist, which is a serotonin receptor that's in the gut. To my knowledge, and I haven't read the package insert, I was not aware that this drug crossed the blood-brain barrier and affected CNS levels or central levels of serotonin to improve mood potentially. So I can't speak as an expert on that, but it does target a receptor in the gut to make the gut go, okay? It causes motility. It causes waves of contractions in the gut, which will help propel stool. So that's how it works. Okay. I think it's a good drug for that. Now, my question for you and for the prucalopride people, or maybe the study authors, is if you look at prucalopride, one of the potential adverse reactions is decrease in mood and suicidality. Okay. So when this drug was first released, we were cautioned to tell the patient it might make you feel depressed and want to hurt yourself. So while I don't think that's true, something led to that being put as a warning on the package insert. So I'd like for us to at least get to the point where we know it doesn't make people want to hurt themselves before we get into talking about how it improves their mental function.
Well, or
Do you get my point?
Yeah, but then it kind of brings up the point: are these people that were doing the study, did they like have those symptoms, or like did they experience that, and then they put them on SSRI, so then it like cleared up their brain fog because they were depressed or something? I don't know how.
Who knows? I don't know, and that's the whole deal with SSRIs. Also, in a select group of patients, may help chronic depression, but you also have to be very careful with manipulating brain serotonin, because in some patients, particularly younger patients, it might increase suicide risk also. So this is sort of like, danger Will Robinson territory. You got to be kind of careful with these and pick the right patients. But prucalopride, to me, would be way premature. This study was small and, again, not definitive in any way. I still want prucalopride. I want to be told that it's not going to cause mental deterioration in a patient, i.e. depression, before I really want to get to thinking about improving mental status or concentration or sense of well-being. I always knew it to be a potential risk to your mental health.
Well, I kind of look at this, and
which I don't see clinically. Patients do really well on it, and
Yeah.
I haven't seen a deterioration or an improvement in mental function. I think it does treat chronic constipation pretty well.
Well, people that are like chronically constipated, or you just feel ick.
That's true.
So it's like,
That's true.
Is the laxative, like, you always feel better after you poop, like you just feel like better. And so it's like, is that what's happening?
Yeah, that's a great question. And I don't want to get too far down this rabbit hole, but as we talk about on this show a lot, medical quackery is alive and well. And there is an old sort of way of viewing things. It's called the auto-intoxication theory, which is where the belief that fecal material and bacteria associated with retained stool is absorbed and recycled in the body and can make patients sick. That's not true, okay? I want to debunk the auto-intoxication theory. That's the genesis for interventions like colonic colonics, colonic hydrotherapy. And in part, this concept of laxatives to improve mental function and overall sense of well-being. That's not the mechanism. The mechanism is more getting to this brain-gut sort of paradigm. And is there low-grade inflammation that may affect mental status and may also affect gut motility via microinflammation, neurodegeneration, brain gut? Is the diet involved, prior infection, psychiatric disorder, and on and on? Really hard to tease those individual components out. But I think it more has to do with brain gut and gut microflora than it does auto-intoxication. So when someone says, I feel bad because I'm constipated and I feel yucky, I think that's true, but it's not because you're absorbing toxins directly from your gut.
Yeah. You just feel...
Now, as I talk it through, I'm almost debunking my own argument. So I kind of see where the auto-inoculation idea comes from. Mm-hmm. They just didn't really know how to... They didn't know... They were actually sort of on the right track a little bit, but I think we've sort of honed that and refined that into this model of brain gut.
Okay.
Now that I've confused everybody.
Yeah, no, I don't know what any of those words were. What? What?
I tried. I am good enough. I am smart enough. And gosh darn, people like me.
And they do. The internet likes you a lot right now.
So I'm just kidding.
I'm not. Okay. Well, that's it for Don't Hold It In. Any other thoughts?
Mm-mm.
I mean, not Don't Hold It In. That's it for
Hot on the Pot.
because we are about to get into Don't Hold It In. So Don't Hold It In. This is where we answer your gut health questions. We read your stories. Any kind of gut health or GI related story can be funny, can be, heartwarming. We want y'all to ask us questions. So if you want to be featured, head over to the Birmingham Gastro TikTok, Instagram, Facebook, or YouTube, or wherever you're watching our podcast, and you can leave a comment or DM us and tell us your question, or ask us your question, tell us your story, and just so we can, this. Our discussion is for educational purposes only and should not replace advice from your own healthcare provider. So now let's see what you've been holding in. Here's questions from TikTok for you, Dr. Shaver.
Or for us. You might have a thought.
Yeah, I mean, maybe. Probably not. What? I don't know if you want my thoughts. Okay.
MD asterisk.
Yeah, that's exactly what it is. Marketing director. Okay. What would cause someone to throw up mucus every morning and be fine the rest of the day?
Sorry.
Don't laugh at this patient. This person.
So this patient's hawking a big lug every morning and then going about their business.
They say throw up.
Next. Okay, throw up. Okay, well, that's interesting. My thought is, I don't think so. Throwing up mucus. There aren't many conditions that lead you to throw up mucus. So the best way I can reconstruct this is that something's happening either late the night before or during the night that is that's affecting this patient so that they feel it in the morning first thing. And I'm wondering if, again, I can only go at face value with this question, but are they coughing? And that leads to what we call post-tussive emesis, which you cough. Have you ever had such a bad cough that made you dry heave or made you vomit? I have. Yeah. So I'm wondering if they're getting a tickle in their throat or some phlegm in their upper airway from a previous infection, maybe some reactive airways, or maybe some nighttime reflux. And they're coughing, dislodging mucus, and then sort of vomiting it all out. That's the best way I can reconstruct this, okay? Because usually vomiting is a forceful expulsion of stomach contents, which is usually not mucoid or mucus containing. I mean, your body makes mucus in the gut, but usually it's not vomited or expelled. So I'm wondering if there's an intermingling of airway and gut vomitus. Vomitus. Word of the day, vomitus.
Okay, well, so what would you tell this patient? That she needs to go get an upper endoscopy?
Well, that would depend. I might tell her that. But I would say, let's talk about the specifics. Like,
You just need the deets.
I want details on this because I think there's an answer. And that's just kind of my reconstruction based on pretty limited data. But I think a good history would sort of flesh out kind of where this is coming from. We might need to do an endoscopy, particularly if we think there's a reflux component, an acid reflux component, or it may be pulmonary. Reactive airways are a form of asthma. So yeah, I think this would warrant additional discussion and perhaps some investigation.
Okay. All right, next question is about something that's trending right now on TikTok. And I know you don't have TikTok, so I'll explain. People are getting applesauce and then they're putting chia seeds in it and mixing it together and then just like sticking it in their fridge or whatever and like eating that.
You could probably make a popsicle out of it too.
That sounds actually horrible.
I had a rosemary and something else, like lime and rosemary one. Probably the same concept. Why would you put
But
rosemary in a
seeds-
popsicle?
Chia seeds and applesauce are like chunky. So I would just eat it as a pudding. So people are eating it as a pudding, or they're putting it on their yogurt. They're eating it in the morning to help them go to the bathroom. So, like, what are your thoughts on that?
Well, my thoughts are I would like to try that. I would like to try, I think so chia seeds are a superfood, like, no doubt. And chia seeds, you mentioned PUFAs, omega-3s, polyunsaturated fatty acids. So omega-3, omega-6, the PUFAs.
I thought you said poopas. And I'm like, wait, what?
PUFA, P-U-F-A, PUFA.
Okay, good, great.
And they're high in protein and high in fiber. And so really, really healthy food. So you want to consume them, but they're kind of gritty. And when you put them in liquids, they get kind of gooey and sticky. So I think this is a texture hack mainly. And for whatever reason, someone found that applesauce was a good sort of way to mix the chia seeds so it gives you a better consistency, so it's more appealing to eat. So I'd like to try chia applesauce. I'd like to try that. It sounds pretty good. Applesauce is applesauce. Get a healthy applesauce that doesn't have high fructose corn syrup and is minimally processed. But I think it sounds like a pretty good idea. And, because again, chia seeds are just these little tiny little seeds that get in your teeth. And so I think this is probably a good way to consume them.
Yeah, chia seed pudding. People like chia seed pudding. I used to make it sometimes when I was on Whole30.
Chia. I had to say that.
I know you did. I'm not surprised. Okay, next question. Go ahead.
I had a chia George Washington bust. And what chia pets?
Yeah.
It was a George Washington chia pet. And
I bet he's so proud that he turned into a chia pet.
That's a little disrespectful to our one of our great founding fathers. But I took care of the George Washington chia pet.
Did you spray it?
And I sprayed it, and we planted and we sprayed, and his hair was filling in. And then I think something happened, but we had some death of some of the chia. Chia, it will grow a little hedge or a little flower. What do you call it? I mean, it grows green.
Yeah.
Green shrub. I don't know.
Yeah.
Anyway, so it was supposed to fill in George Washington's head with hair, and he developed male pattern baldness because it died right there in the front. And so I had a bald chia pet George Washington bust, and didn't work out great. But
that's
chia.
Chia. Yeah, that sounds.
We live in a digital world where there's just no room for chia pets anymore. There's really not. I say bring back the chia. Bring back the chia pet. Let's learn about gardening and farming with the chia pet.
Okay. People have actual plants now, and plants are like a thing.
They do.
So that's their pet.
But I think that chia pet is a toy or
for the children. Hence
for the children,
chia.
Not super popular anymore.
Yeah, obviously. I wonder if they're still a company.
We should can we do chias of all of the partners at BGA and maybe even do like facial hair chia sprouts?
Great.
And
we'll do that.
To kind of simulate. That would be kind of fun.
We can make it on, we can sell those online.
We could.
Yeah. With our calendar that we are supposed to make. I'm just kidding. Okay, another question. My husband and daughter have FAP. I would love to be more educated on that disorder.
FAP, so familial adenomatous.
Familial.
It's FAP. Familial adenomatous polyposis coli. It is a autosomal dominant genetic polyposis syndrome of the intestinal tract that results in massive quantities of precancerous polyps throughout the gut, mainly the colon, also the stomach, also the small intestine. And The risk of colon cancer is, in this condition,
High.
a 100% at a young age.
Oh.
So this will cause colon cancer, which is why it's so important to know it and understand it. It will cause cancers in very young people. I think the median age is in the 20s or early 30s. So you start screening these patients very, very young. And the main thing to know is these patients will require a proctocolectomy. So their rectum and colon have to be surgically removed to prevent colon cancer. And then they need to be aggressively surveillanced with upper endoscopy and pouchoscopy. So upper and lower endoscopies to survey for precancerous polyps for the rest of their lives, usually at annual intervals. There are other associated cancers related to that, so you need to really speak to your gastroenterologist to talk about screening protocol. I will give a shout out to genetic counselors. They are invaluable in this condition and other heritable colon cancer syndromes because they are way better than us at really making sort of comprehensive formal recommendations about screening programs. And helping patients to really understand the genetics behind this because that's what they do every day. And so a good genetic counselor is really valuable, and I use them a lot with these patients to educate.
Good to know. Okay. Next question, and this one's great because I was at a primary care office today doing a visit, and they were talking about the big jug that people use for colonoscopy prep. And I was like, wait. There are so many other options now. So I've got to do the Go Lightly prep for a colonoscopy. Is there a reason some gastros prefer one prep over another?
Yes.
And we used a couple different preps.
We do. So just a short list of reasons we choose one or the other. Some preps are gentler on the kidneys. So some patients with chronic kidney disease or chronic liver disease or congestive heart failure need a specific prep with different components. Okay, they're going to be safer for the kidneys or other organs. So sometimes it's based on the patient. Sometimes it's based on what their insurance will cover. Mm-hmm. Okay, so that's a big factor. Sometimes it's based on patient preference. Do you want a liquid? Do you want a pill? There is a pill prep. That is, you just take a bunch of pills and drink a lot of water and fluids with it. And then sometimes we use larger volume or 2-day preps because one normal prep's just not enough and the patients don't get clean with it. So lots of different factors that determine what prep we use, but we do try to customize it, give the patients some general, menu of choices, but try to customize it to the patient.
Okay, next question. Does being on a GLP-1 hinder, this is evacuation, but I think it means evaluation before colonoscopy.
I think it meant evacuation.
Does it?
I think it might mean, does this make it harder to get cleaned out?
Okay.
For your colonoscopy, kind of piggyback on the last topic. So it can. So that's why, we do have you hold it 1 week before the colonoscopy, and you're obviously on clear liquids the day before, so that sort of gets it a little bit out of your system so you can flush out. So it usually is not an issue. I don't see a major impact on the quality of my bowel preps on my GLP-1 patients, so I wouldn't worry too much about it. But in some patients, it does slow intestinal motility, so it might make it a little more difficult on a regular basis to have normal bowel movements.
Okay. Okay, quick story on this one. My family had a round of the stomach bug over the weekend. My husband was drinking water to stay hydrated with blue-colored Mio liquid drops. After drinking it, his stool was lime green, teal color. Did you see this?
I did see it.
Did you see the picture?
I didn't see the picture.
It was somebody that works at your endoscopy center.
That's
you
good.
You want to see it?
Sure. Neon green.
Neon green. But they all had the stomach bug. I'm like, wait, did y'all have this parasite thing? I'm just kidding.
What does that tell you? What is It kind of
I love how people send
reminds me of like the ghost goop on Ghostbusters. Kind of like that. Kind of that kind of Ghostbusters green. That tells me that number one...
It was after blue Mio drops, which are not electrolytes. That is a flavor-enhancing thing for water.
So here's how we got that. Number one, the Mio-enhanced water really shot through this person.
Yeah.
And how did you get green out of blue? Well, this is how. The blue food coloring, the blue dye, mixed with the yellow bile to make green.
Ew, gross.
Is blue and yellow make green?
Yeah, I think so. I don't know. I'm not an art major. Let's find out. Yes.
So blue Mio plus yellow bile equals green Ghostbuster colored poop.
Does blue
Residue.
Yes, it does. Okay, wait, sorry. Wow. All the my art teacher's going to be mad at me. Yeah, no, that's disgusting. But thanks for sending that. She showed it to me the other day, and now people send me pictures of their poop. But anyway.
That's one of those things you're like, I mean, thanks.
No,
thanks
I'm glad
for
she
that.
did.
Thanks for sharing.
Thank you for sharing that with us. Because that is interesting and it's disgusting. And it gives us the opportunity to let people know that is a flavor enhancer for your water, not electrolytes. I think that's important to know because people think those are electrolytes and they're not.
I mean, I guess that's good if it encourages you to drink water, but probably just fake sugar, food dye, liquid.
Sure. Yeah. Speaking of colors, do you use this special dye to help spot flat polyps in patients with hereditary colon cancer syndromes?
So we don't routinely do that. So that's chromoendoscopy, and that's been around a long time. And that's where you spray a vital dye like indigo. There's several. There's a violet, there's an indigo, carmine. There's several different vibrant or vital dyes. And you just spray the whole colon with it. And precancerous or subtle flat polyps in genetic syndromes or in inflammatory bowel disease will not tend to take up the dye. They're dye resistant. The normal colon lining is dye sensitive. It picks it up.
Interesting.
So they'll stand out and you can remove them. It's extremely tedious and time consuming. And now the scopes have a button you can push that will do essentially the same thing. It's a filter. And so normally the scope light source is just white light. Mm-hmm. It's high resolution white light. Well, the optics are high resolution. The light's white, but we can click on this narrow band imaging button and it will give us a filtered look. So now we just use the technology built into our scopes to virtually dye your colon.
Oh, that's neat. Okay, I didn't know that.
Yep.
Okay, two more questions. If I had my esophagus stretched in 2021, is it common to need this again and again, mainly for food getting stuck?
It's not. Yes, that is. Some people, so strictures of the esophagus, which are scar rings, which narrow the esophagus and can cause food to hang up, that's scar. So once you have scar, it's there. So we can stretch and gently break apart this scar, but it can reform. It has some elasticity, so it sort of like tends to boing back into to place. So we do have to often re-stretch or re-dilate these strictures. So that's not unusual to have repeat esophageal dilations.
Okay, last question. So what's your reaction to your recent TikTok fame? Have you
My
even read
reaction,
through it? Did you do what I said to do?
I believe I subscribe to the school. First of all, until we break into the top 100 of health and wellness podcasts, none of it matters. So I'm going to leverage comments to hopefully grow this podcast, and so it can reach more viewers and listeners so that they benefit from our content. That's what matters to me.
Sweet.
And comments we can use to So I appreciate any nice comments. I also appreciate constructive criticism comments because that's fine too. Because we don't always get it right, and I've been a little bit harsh today. I'll acknowledge that. But
believe in yourself.
Okay. But what we will tell you is the truth as we see it, and we're not going to ever try to deceive you, and we're going to try to just straight shoot about GI stuff. And so it's nice that people are appreciating that. I do want to continue to grow this and get into the top 100.
So is that your reaction? They all want a reaction.
Maybe
I'm just going to have you read these like they do on
late night shows
that are like mean tweets, but they just wanted a reaction. So that's it.
My reaction is keep following us. We're going to keep this informative and very entertaining.
And stop making comments about him is what he's saying.
Whatever you need to do.
I got a kick out of him.
But
I just make you feel awkward. Okay, good.
No. Great. No, this is the world we live in, is TikTok. And look, your fans can be your haters just overnight. So
they're not haters.
I have a very balanced perspective, and I think it's helpful to not read the press. But again, we are a small fish in a really big pond of health and wellness podcasts. So we want to grow this. So I want all those people that like me and like what we're doing here to share the content.
You're so humble.
Share the clips so that we can reach more people.
Some of our doctors...
We're better than a lot of the podcasts that are in the top 100. I can tell you that right now. So we need to eke up and get into the top 100.
Some of our doctors that were featured in that video, which now has 400,000 views and like 36,000 likes.
The rage bait video?
Yeah.
Okay.
They downloaded TikTok on their phones so that they could go look at the comments. Unlike you, who's definitely not going to do that. I just screenshot them and send them
what would you feel like if you were a real podcast host?
I mean, I'm not, so... Maybe this would be doing a lot better. Maybe we'd have our own studio.
See what I did there?
You're funny. I knew what you were doing there. Anyways, okay, well, that is it for Don't Hold It In. If you've got a question or a story, don't hold it in and send it to us on Birmingham Gastro's Instagram, Facebook, or TikTok, or comment it on the podcast wherever you're listening. And your story or your question could be featured on a future episode of The Flush. And then, yeah, I guess that's it for today. We've been going for a really long time. Oh my gosh. Wow. Oops. That's a wrap. Thanks for joining us on The Flush, where we make gut health easier to understand and a lot less awkward to talk about. Before you flush this episode, be sure to subscribe or follow the show, leave us a review, and share it with someone who gives a crap. And keep things regular, and we'll see you on the next episode of The Flush.